Welcome to Lesson 5. In this lesson, we're going to be focusing on stimulants, which are a class of substances that increase activity in the central nervous system. And this lesson is important because stimulant use can look very different from alcohol and depressants or opioids. And if you don't understand that difference, it's easy to misread what clients are experiencing. Stimulant clients, they may present as highly energized, they're restless, they're emotionally intense, they're suspicious, they're impulsive, they're just generally unable to slow down. And in other situations, they may present in like a crash phase. They may seem like they're exhausted or depressed or just completely shutting down. And both presentations can be tied to the same category of substances. And that's one of the reasons that this lesson matters so much. Stimulants are tending to create strong changes in mood and energy and sleep and their ability to pay attention and their behavior. And it's also affecting their risk-taking, and it's going to contribute to them having paranoia and aggression and psychosis, especially with the heavy or the prolonged use. And these are the kind of things that counselors often see in practice, but they may not always connect directly to the pharmacology. So this lesson is going to help you make those connections. So we're going to focus on common stimulants like cocaine and methamphetamines. But we also talk about stimulant type patterns more broadly. So we learn how stimulants affect the brain, what intoxication and withdrawal can look like, what risks are going to matter most from the counseling perspective, and we're going to look at how stimulant use affects sleep and emotional regulation and impulse control, and also whether they're engaging in treatment. And as always, the goal is not just to simply memorize the facts. The goal is to help you understand what you're seeing in real clients and respond more effectively. So by the end of this lesson, you should feel much more prepared to recognize stimulant-related patterns and talk about them clearly and apply that understanding in assessment and your counseling education and also in your referrals. So stimulants are substances that are increasing activity in the central nervous system. And that means that they speed things up rather than slowing them down. So in practical terms, stimulants are increasing energy and alertness. They're making the client more wakeful and have a higher activity level. And that's going to increase that client's confidence. They're going to be more talkative, more focused, and they're going to have more motivation, well, at least temporarily. And that's part of what's making that appealing to them. A person may feel more productive or more social or more powerful, or maybe they feel more capable while they're using them, but those short-term effects come with significant risks. Stimulants are also going to increase your heart rate, your blood pressure, your restlessness, and your impulsivity. And that's going to interfere with your sleep, and it's going to make your anxiety worse and create this intense cycle followed by a crash. And some stimulants are prescribed, like meds for ADHD, and others are illicit, like cocaine or methamphetamines. And from a counseling perspective, what's going to matter most here is not just whether the substance is legal or illegal, but how is it being used and what are the effects that it's having on this person? Because clients may not always identify stimulant use as especially dangerous because it's not always causing the same kind of sedation that's seen with opioids or alcohol. In fact, stimulant use can look highly functional at first. Maybe the client's reporting that they're more productive or more awake or they've been able to work longer hours. But over time, those same substances are seriously going to disrupt their sleep, and it's going to create emotional instability, and it's going to strain their cardiovascular system. And understanding stimulants is going to start with understanding that they're creating a state of increased activation in the body and brain. And that activation may feel helpful or rewarding initially, but it becomes dysregulating over time. And so as counselors, we need to look beyond the immediate effect and understand the broader pattern of impact. And that's what's going to guide better assessment and better intervention. So there's several types of stimulants that you're going to encounter in practice, and each has a slightly different pattern of use. They each have different reputations and presentations. So cocaine, this is one of the most well-known stimulants, and it's often used recreationally in powder form. Crack cocaine is a smokable form of cocaine that produces a more rapid and intense effect. Methamphetamine is another major stimulant, and it's often associated with longer lasting effects. It has a higher intensity and more severe long-term consequences. And you may also encounter prescription stimulants like Adderall or Ritalin or Vyvanse. These medicines have legitimate medical uses, especially in treating ADHD, but they can also be misused. And clients may use them in ways that differ from how they were prescribed, or maybe they're taking someone else's medications. Maybe they're just using them to stay awake or lose weight, or they feel like it's going to increase their productivity. College students are this is a popular drug of choice to stay up and focus in studying for tests. And the client may not see this as substance misuse because it's a medication that's prescription based, which is why we need to change our assessment language to start asking these questions. And then there's also illicit stimulant mixtures and unknown substances in the drug supply. Just like with the opioids, substance purity and context can be really unpredictable, and a client may not fully know what they're using, especially if the substance is purchased in an unregulated setting. And this unpredictability matters because it changes the risk. So from a counseling standpoint, it's important to ask specifically about different stimulant types rather than just asking, hey, do you use drugs? The client may report coke or meth or speed or addies or other slang terms. They may say ice, which is methamphetamines. And the more familiar that you are with the common categories, the better your assessment's going to be. And that's going to help you understand their patterns of effect, because cocaine and meth and prescription stimulant use, that may overlap in some ways, but they're going to differ in intensity and duration and what the associated risks are. So stimulants, they're primarily affecting the brain by increasing the activity of certain neurotransmitters, especially dopamine and norepinephrine. As I talked about before, dopamine plays a major role in motivation and reinforcement and behavior repetition. Norepinephrine is involved in arousal and alertness and attention, and it affects the body's stress response. And when stimulants are increasing these neurotransmitters, the result is going to be a state of heightened activation. And that's why stimulants make the person feel awake or energetic, and they're more focused and driven. And it's also why they're going to create a powerful reinforcement pattern, because the brain's going to start to associate stimulant use with productivity and motivation and confidence, or maybe even pleasure. And then over time, that can make the stimulant use highly compelling, especially for people who feel tired or depressed or overwhelmed, or maybe they're underperforming when they're not using. And the problem here is that this increased activation is not neutral. It's placing the brain and the body in a heightened state that can become unsustainable. And so the person sleeps less, they eat less, they become more impulsive, they're experiencing stronger emotional swings. And what starts as an increase in focus or energy can turn into agitation or irritability, paranoia, or exhaustion when those effects wear off. And as a counselor, understanding these mechanisms is going to help you explain why stimulant use can be so reinforcing at first. Even while creating the serious long-term consequences, it's still reinforcing it. And it's going to help you to understand why stimulant withdrawal also is going to involve a crash. So if the brain has been pushed into a high activation state, the rebound can feel intense when the substance is removed. And this connection between neurotransmitters and presentation is central to good stimulant counseling. So we know that stimulants have a particularly strong relationship to dopamine, which is part of what makes them so reinforcing. When stimulant use causes dopamine to rise quickly and intensely, the brain's going to interpret that experience as highly significant. And that's not just creating pleasure, it's creating a powerful drive to repeat those behaviors. So the person is going to start to associate stimulant use with energy and success and confidence and social ease or emotional escape. And that reinforcement can be especially powerful because stimulant users often connect the substance not only with just feeling good, but functioning better. And so the client may say that they're getting more done, they're thinking faster, they're talking better, they're feeling more capable when they're using. And that's creating a different kind of attachment than just simply chasing that euphoric effect. And it ties the stimulant use to their identity and how they're performing and their perceived competence. And then over time, the repeated dopamine flooding is going to reduce the brain's natural reward responsiveness. So that means that, maybe the person starts to feel flat or bored or unmotivated when they're not using. Everyday tasks feel less rewarding. It's kind of like, oh, this is it, you know? And that's going to increase their urge to return back to that stimulant, not only just to feel high, but to feel normal and energized or effective. So as a counselor, this is important because it's going to help explain why stimulant clients may feel deeply resistant to stopping, even when the consequences are severe. They may not just be giving up a drug. They may feel like they're giving up the one thing that, that's helping them feel capable. And understanding that dynamic is going to help you respond with more accuracy and less judgment while still addressing the seriousness of the pattern. So norepinephrine, this is another key neurotransmitter that's involved in stimulant use, and it's going to help explain, like why stimulant clients often appear wound up or tense or reactive, like they're unable to settle down. The norepinephrine is really closely tied to the body's stress response. So it's going to increase the person's alertness and raise their heart rate. The body's preparing to respond quickly to perceived demands or threats. So in like the small or the natural amount, the system is adaptive. But in stimulant use, it's going to become exaggerated. And when the norepinephrine is pushed too high, the person's going to feel like hyper alert or intensely focused at first. But that can easily shift into anxiety or irritability, or maybe they feel suspicious or they're having panic-like experiences. And their body is effectively, operating in an overactivated state. And this is one reason that stimulant users look like they're always on edge or primed for conflict. And that's going to help explain the physical strain that the stimulants cause. So that's like the elevated heart rate. They're going to have high blood pressure, muscle tension, reduced appetite, and all of that reflects a body under stimulation. And maybe the person feels energized, but their system is under stress. And if that pattern continues over time, the physical wear and tear is going to become significant. So for counselors, understanding norepinephrine is going to help with both assessment and interpretation. And if a client's easily startled or highly reactive or intensely anxious, maybe the use is playing a role. And if they maybe are describing like they can't shut their brain off or they can't calm down, that's also consistent with this pharmacological pattern. Recognizing that link is going to help you address the presentation more accurately and avoid oversimplifying the behavior as just purely personality-based or oppositional. Cocaine is a very powerful stimulant, and it's tending to have a shorter duration of action, like compared with like methamphetamines, because the effect is going to come on relatively quickly and it's going to wear off more rapidly. And so that leads to repeated dosing in a short period of time. And that creates binge-like patterns for a lot of users where, they're taking the drug again and again because they're trying to maintain that desired effect. So the clients may describe cocaine as making them feel more energized or more confident or more talkative or more social. And in the short term, it creates a strong sense of intensity and momentum. But because the effect is relatively brief, the drop-off can come very quickly too. And that creates this cycle of chasing the high. And they're trying to avoid the crash. So cocaine can either be snorted, smoked, or injected. And the route of administration affects how quickly it hits and how intense the effect feels. Faster routes of administration are usually going to increase both reinforcement and risk. And the quick onset is going to create a strong connection between the use and the effect. And that strengthens the compulsive pattern. So from a counseling standpoint, cocaine users might present with patterns of binge use. They're going to have financial instability. They're going to make impulsive decisions. They're going to have sleep disruption. They're going to be irritable. They're going to have crashes in mood or crashes in energy. And they're going to minimize how serious their use is because they don't see themselves as sedated or visibly impaired in some way as someone maybe using alcohol or opioids. So understanding the cocaine cycle is going to help you identify that the pattern may be more severe than the client's language is actually suggesting. Methamphetamine, this is another major stimulant, but it does tend to have longer lasting and often more intense effects than cocaine. And this matters because the duration of action is going to shape both the experience and the consequences. So clients using methamphetamines may stay awake for extended periods, or they're going to eat very little. They're going to remain in an activated state for a lot longer than somebody using a shorter acting stimulant. And this prolonged activation is going to increase the risk of more severe behavioral and psychological effects. Sleep deprivation becomes a major issue, and that alone can just significantly worsen mood and their thinking and their perception. So, like a client who's been awake for a long period of time, they're going to be irritable and disorganized. They're going to start to get suspicious and maybe even a little psychotic. And this is just one reason that methamphetamine use is so strongly associated with paranoia and bizarre behavior. Methamphetamines initially may be experienced as like highly productive or energizing, and the client feels unstoppable. They feel focused and powerful, and maybe they feel unusually capable. But over time, the cost becomes a lot more visible because they're going to start to physically deteriorate. They're going to be emotionally volatile. They're going to start doing skin picking. They're going to have dental issues. They're going to create social chaos, and then they're going to have intense crashes. And all of these are common patterns. They're not just one-offs. They are typical. So as a counselor, it's important not to reduce methamphetamine work to just stereotypes. Some clients are going to fit that dramatic picture that people expect, but others might not. Some may still be employed or organized in certain areas, or highly defend their use. The pharmacology is still going to matter here. The longer duration, stronger reinforcement, and the stronger sleep disruption are going to make methamphetamines a very serious substance, even when the person appears superficially functional for a while. Now, prescription stimulant misuse, this deserves careful attention because clients often minimize it or they fail to identify it as substance misuse at all. And some clients take more than prescribed, or they use medication differently than it was intended, or they take it for reasons outside of medical guidance. Others may use somebody else's medication to stay awake or study longer or work harder, or maybe they're trying to suppress their appetite or improve their mood. And the fact that these medications are prescribed can create a false sense of safety because the clients might assume that because the drug has a legitimate medical use, that the misuse is less serious. But in reality, the misuse can still lead to dependence patterns or sleep disruption or mood instability. Maybe it leads to anxiety or cardiovascular strain and a distorted sense of self-perception around their functioning. So, stimulant intoxication often presents as a picture of excess activation. The client may have increased energy, rapid speech, restlessness, an inability to sit still or slow down. They're going to appear highly focused on some topics, but they're going to seem like scattered overall. Their appetite is often reduced, and their sleep may be delayed or just skipped entirely. Some clients also present with like elevated confidence or a sense of being especially capable or productive. They may seem like they're more insightful. And in mild cases, this just looks like unusual energy. And in the more severe cases, it looks like grandiosity, impulsivity, irritability, maybe even pressured thinking. And the exact presentation depends on the substance, the dose, the route of administration, and the person's just baseline functioning. But it's important to note that stimulant intoxication doesn't always look happy or euphoric. It can look anxious and edgy and suspicious. So a client may appear energized and distressed at the same time. And that's going to make the presentation confusing if you're expecting only one type of behavior. So as a counselor, your role is to observe and assess. So maybe you notice fast speech, pacing, an inability to focus, agitation, or maybe unusual intensity. And these observations are going to help inform both your documentation and your clinical decision making. Understanding what stimulant intoxication looks like helps you to respond more appropriately in the moment and plan more effectively over time. Another thing, you might see their eyes darting back and forth, or you may see their jaw like moving in odd manners, or maybe they're moving their fingers in a kind of like a weird way, and it's not normal how they're moving their hands or their jaws or their eyes. So after the intoxication comes the crash, and this is just as important to understand as the high itself. When the brain and the body have been pushed into a highly activated state, they're often going to rebound in the opposite direction once the substance wears off. And that's going to lead to intense fatigue, low mood, irritability, and just a strong desire to sleep. You may see them sleep for an entire day or like 3 days straight. Clients in a stimulant crash may look completely different from how they appeared while they were intoxicated. They're going to feel flat, depressed, withdrawn, they're unable to function, and this dramatic contrast can be really confusing if you don't understand the stimulant cycle. A person who seemed highly activated yesterday may seem emotionally empty or profoundly exhausted today. And the crash can also increase risk. Some clients use, again, pretty quickly to avoid the emotional or the physical discomfort of coming down. And that contributes to binge patterns and repeated dosing. Other people may become deeply depressed, and that's going to increase suicide risk in some cases. That means that the crash phase should not be dismissed as just simply feeling tired. So as a counselor, you need to be prepared to ask about the full cycle of use, not just the active high. Our clients are going to describe using for days and crashing hard and sleeping excessively and then starting again. And that pattern gives important clinical information about severity and risk and treatment needs. Because understanding the crash is going to help you interpret the mood symptoms and their motivation and attendance in a more accurate way. Withdrawal from stimulants, this is going to be different from opioid or alcohol withdrawal, but it still matters greatly from a counseling standpoint. It's typically not medically dangerous in the same way that alcohol withdrawal can be, but it is psychologically intense and it is highly disruptive. The common symptoms are going to be low mood, strong cravings, sleep disturbances, low motivation, irritability, difficulty concentrating. A client in stimulant withdrawal is going to feel more emotionally drained. They're going to feel hopeless and empty and just unable to enjoy anything. And that's tied to the dopamine disruption and the contrast between the high activation state that was created by the drug and then the depleted state that's following that. So the person may sleep a great deal, or they may have an irregular sleep pattern, and they're going to struggle with self-care and paying attention and just basic daily functioning. And these symptoms are going to contribute strongly to them relapsing. Because if they're feeling flat and miserable and just unable to function without the stimulant, then they're going to go back to using, not just for the pleasure, but to escape the crash in the withdrawal state. And that's one reason why stimulant withdrawal needs to be taken seriously, even though it is less medically dramatic than some of the other substances. And as a counselor, it's going to be important to normalize the difficulty of this phase without minimizing it. The client needs to understand that these symptoms are part of the withdrawal and the recovery process. It's not proof that they're permanently incapable of functioning without the drug. And this is also an area where support and structure and sleep stabilization and close monitoring is going to make a major difference. And as I've been saying, sleep deprivation is one of the most important factors in stimulant-related presentations, especially when the methamphetamine use, but like also with cocaine and prescription stimulant use. When a person stays awake for a long period of time, their brain starts to function differently, even without any other complicating factors. So mood becomes less stable. Their concentration gets worse. Their perception becomes distorted, and their irritability increases. So when the stimulant use is driving that sleep deprivation, the effects are going to be amplified even more. And a lot of the severe behavioral changes that are associated with the stimulant use, they're in large part influenced by the lack of sleep. So a person who has been up for 2 or 3 days is going to start to be really highly suspicious and emotionally volatile. They're going to be disorganized in their thinking and their speech, and they're going to be reactive. And they're going to misinterpret other people's behaviors. They're going to feel like they're being watched. They're going to struggle to think clearly. And in some cases, this escalates into stimulant-induced psychosis. And this matters because sleep deprivation can make a client appear more aggressive or unstable or out of control than they might otherwise seem. So as counselors, we need to understand that this is not just a character issue. It's also a physiological and a neurological issue. And so asking about sleep is not a side question in stimulant work. It's central. And the clients may minimize their sleep loss by saying that they're just up a lot or they're not really tired. But if the pattern is severe, you should view that as a significant risk factor. Sleep restoration is often a major part of early stabilization. Recognizing how sleep deprivation contributes to the stimulant symptoms is going to help you understand the presentation more accurately and be able to intervene more effectively. And paranoia is one of the most common and serious psychological effects of stimulant use, particularly with heavier use or longer periods of being awake. So the clients may become suspicious of other people or feel like they're being watched or misinterpreting neutral events as threatening, or maybe they believe that other people are talking about them or trying to harm them. And this can range from mild suspiciousness to full-on delusional thinking. And it is important to understand that stimulant-induced paranoia is not always dramatic at first. It may begin as like increased guardedness or discomfort or mistrust. The client may start reading too much into small cues or become unusually defensive, or maybe they react strongly to situations that seem minor. And then over time, especially with the continued use and the sleep deprivation, this can intensify significantly. So, as a counselor, this is an area where your approach is going to matter. If a client's paranoid, direct confrontation about the irrationality of the belief may increase the distress and the mistrust. A more effective approach is usually just remain calm, focus on safety, avoid validating any false beliefs while also not escalating the interaction. You can acknowledge the client's fear or distress without agreeing with the inaccurate conclusion. Understanding stimulant-induced paranoia is going to help you avoid misreading the clients as simply difficult or manipulative, or looking at them as like, oh, this person is oppositional. It's going to help you assess when a higher level of care or psychiatric evaluation may be needed. And this is a good example of how pharmacology and mental health symptoms are overlapping in ways that require careful clinical judgment. And stimulant-induced psychosis is one of the most serious possible outcomes of stimulant misuse. This involves having hallucinations, delusions, severe suspiciousness, or disorganized behavior and thinking. And it's more commonly associated with methamphetamines than some of the other stimulants, but it happens with multiple stimulant types under the right conditions. So heavy use and prolonged wakefulness, these are two major contributors. When the brain has been overstimulated for a long period, perception and thought processes may become significantly distorted. So a client may hear or see things that are not there, or they become convinced that they're being followed, or they're behaving in ways that appear bizarre or just disconnected from reality entirely. And this presentation can be frightening for the client and for the people around them. And it can also easily be confused with like primary psychotic disorders. And, while diagnosis is outside of the counselor's role, recognizing that possibility that stimulant use is contributing to psychotic symptoms is extremely important. The substance use history, the timing, their recent sleep, and their pattern of onset are all going to matter. So as a counselor, safety becomes the priority in these situations. The client may need urgent medical or psychiatric evaluations. Trying to conduct routine counseling with somebody in a stimulant-induced psychotic state, that's not appropriate. Understanding that risk is going to help you recognize when the situation has moved beyond standard counseling intervention and it requires more immediate support. And we know that stimulant use also shows up in physical signs, so it helps us to understand it clinically. One common issue is skin picking. Clients may repeatedly pick at their skin, and sometimes that's because of anxiety or hyperfocus, or maybe it's the sensation that something is on or under the skin. And over time, that leads to sores and scarring or an infection. Then there's dental deterioration. That's another well-known issue, especially with methamphetamines. And that's influenced by a couple of different factors like dry mouth, poor nutrition, grinding their teeth, poor hygiene, and overall neglect during binges. Weight loss is also common, especially when stimulant use suppresses appetite over time. So it's important not to reduce a client to these visible signs or to use them in a judgmental way. But they can provide important information about the severity and the duration of the use. So if a client appears physically depleted, they have visible sores, marked weight loss, or significant dental issues, those are not cosmetic concerns. Those are clues about what the substance use is doing to their body and their daily functioning. So as a counselor, you should document objective observations and connect them to the broader clinical understanding. Physical signs are often telling part of the story that the client may not fully articulate. And it's also reinforcing that stimulant use is not only about mood and behavior, it affects the whole person. And stimulants are going to place significant strain on the cardiovascular system. They're increasing the person's heart rate and their blood pressure. And that may not be obvious to the client until the symptoms become severe. Some clients are going to experience chest pains, palpitations, a shortness of breath, maybe intense physical discomfort during or after use. And in the more serious cases, the stimulant use is going to contribute to heart attack and stroke and heart arrhythmias and other dangerous medical events. And that matters in counseling because the clients often underestimate the stimulants related medical risk. Some may assume that because they're not sedated or they're not overdosing in the same way that opioids do, that the use is less dangerous. But in reality, the stimulant-related emergencies can happen suddenly and they can be fatal. So a younger client may wrongly assume that they're not at risk, and that may increase their carelessness. And as counselors, we need to understand these risks well enough to recognize when a client's report suggests the need for urgent medical attention. Also, chest pain during stimulant use should never be brushed off. Severe headaches, neurological symptoms, or major cardiovascular complaints should be taken seriously. Even when the presentation is less accurate or less acute, these risks are part of the education conversation. The clients need to know what's on, like the ongoing stimulant use is not just affecting their mood and their behavior. It's putting a serious strain on their heart and their blood vessels. And that broader understanding is going to help support more accurate risk perception. And cocaine and alcohol are often used together. So I need to give a little bit of special attention to this combination because it creates its own unique set of risks. When cocaine and alcohol are used at the same time, the body's going to produce a metabolite called cocaethylene. And this substance can increase toxicity and place even more strain on the cardiovascular system than just cocaine alone. So clients may use alcohol with cocaine for a lot of different reasons. Some want to come down more smoothly. Maybe they're trying to reduce their anxiety or extend the social experience. Others are just simply using both because they're both in the same setting. But from a pharmacological standpoint, the combination is particularly concerning because it's increasing the risk of heart-related complications and it can worsen impulsive decision making. And this is a good reminder that risk is not only about single substances. It's also about the combinations and the new effects that are created by those combinations. And the clients often underestimate this. They think of alcohol as separate from cocaine rather than understanding that using them together changes the risk profile significantly. So as a counselor, there's another area where specific assessment is going to matter. Don't just stop at, do you use cocaine? Ask what else is typically used with it. And those details can reveal a much more serious clinical picture than the client is initially presenting. Now, stimulant use is pretty often going to produce some noticeable functional consequences, especially over time. Relationships are going to get strained because the person's irritable or suspicious, or they're going to have emotional volatility or emotional inconsistency, or they're just going to disappear during binges. Their employment's going to suffer because they're missing work, they're having erratic performance, their crash periods, the behavioral problems. They're going to have financial instability, and that's going to develop pretty quickly because stimulant use can involve repeated purchasing in short time periods, especially during binges. They're going to have legal issues, whether it's through possession charges or their behavior during intoxication. Maybe it's involving theft or driving related incidences or conflicts with other people. They're going to have emotional volatility. That's going to affect every area of their life. The client may swing between confidence and despair, productivity and collapse, charm, and aggression. And they're going to swing back and forth all within a relatively short period of time. So from a counseling standpoint, these consequences are going to matter because they often become the reason a client enters treatment. Even if the client doesn't initially identify the stimulant use as the true driver, they may present saying something like they have anger problems, or maybe they have sleep problems, or depression, or they have a relationship issue or a legal issue. And your job is to explore whether the stimulant use contributed to those or they intensified those issues. Because that's another reason why pharmacology is going to matter. If you understand the typical pattern of stimulant impact, you're more likely to ask the right questions and identify the real clinical picture. The substance use may not be the only issue, but it is often shaping the entire system of functioning around the client. So good stimulant assessment is going to require more than just asking whether the client's using cocaine or meth. You need to understand the pattern. What stimulant are they using specifically? How often are they using it? How much are they using? Are they using in isolated doses or in extended binges? And these details are going to make a major difference in risk and presentation. Asking about sleep is especially important because if the client is staying awake for a long period of time, that significantly changes the clinical picture. It's going to increase their likelihood of psychosis and confusion and paranoia and emotional instability. And asking what happens during that crash is going to be equally important. Do they sleep for long periods? Do they become depressed? Do they use another substance to come down? Do they start using again quickly? These kinds of questions are going to help you understand not just the presence of the use, but the full cycle. And that cycle is what is often driving impairment and relapse. And it's also going to give you more clinically useful information than just a simple yes or no question ever will. And as a counselor, a detailed assessment is one of our best tools because it's going to help us identify the severity of their use and understand what their experience has been. And that way we can choose the most appropriate intervention to focus on. In stimulant work, the pattern is going to tell us as much as the substance itself. So certain clinical red flags in stimulant work should raise your concern immediately. And one of the biggest is prolonged lack of sleep. I can't stress this enough. A client who has not slept for an extended period of time is at an increased risk for emotional and cognitive disturbances. Increasing paranoia, that's another major warning sign, especially if the client's becoming more suspicious or fearful or they're reacting over time. Aggression and extreme irritability, that's also going to matter. Not every stimulant client's going to be aggressive, but the combination of the sleep deprivation and the heightened arousal and the impaired judgment, all of that's creating a volatile presentation. Repetitive binge crash cycles are going to suggest a strong and destabilizing pattern of use that may be difficult for the client to interrupt without substantial support. Physical deterioration like weight loss, sores, exhaustion, visible depletion, that's another red flag. Chest pain, severe headaches, other maybe possible cardiovascular symptoms, we always need to take those seriously, and that's going to require urgent medical evaluation. So recognizing the red flags is going to help you identify when the situation may be moving beyond routine counseling and into a level of severity that's maybe requiring higher urgency or a stronger coordination or additional referral. Because this is just one of the main clinical functions of this pharmacology knowledge. So when a client presents with stimulant-related agitation, paranoia, or instability, your own response is going to matter a great deal. Staying calm and regulated is essential. A highly activated client may become even more distressed if they're perceiving you as confrontational or chaotic or dismissive. Your demeanor is either going to help stabilize the interaction or contribute to the escalation. Safety is going to come first. So if a client appears significantly impaired, If that person seems like they're psychotic or aggressive or they're just medically unstable, that needs to guide your response. It may not be appropriate to continue routine counseling as though nothing unusual is happening. The first question is not always, how do I get through this session? It may be, is this person safe and is this setting appropriate right now? Do I need to stop what I'm doing and seek attention? We want to avoid escalating the confrontation. That doesn't mean that we're ignoring concerns or we're agreeing with their distorted beliefs. It means that we're responding in a steady, grounded way that doesn't unnecessarily intensify the situation. If symptoms exceed the outpatient counseling scope, the referral becomes essential. And that may mean medical evaluation, maybe psychiatric support, crisis response, or maybe a higher level of care. And this is another area where understanding the pharmacology changes your effectiveness. So instead of taking the client's presentation personally or reacting only behaviorally, you're interpreting it through a more accurate clinical lens. That's going to allow for better judgment. It's going to help you set better boundaries and provide safer care. And documentation in stimulant cases needs to be clear, objective, and behavior focused. So if the client appears restless, they're speaking rapidly, they're reporting being awake for several days, or they're describing paranoid thinking, document those observations specifically. Avoid the vague labels when there's more concrete language that's available. Objective description is especially important when the presentation is intense or unusual. Sleep deprivation needs to be documented when it's relevant because it often explains or contributes to the clinical picture. Behavior patterns like binging and crashing, aggression, or even like the severe irritability, that needs to be noted clearly. If you have concerns about safety or psychosis or medical issues, those concerns and the basis for them should be reflected in the record. And education is going to matter here too. If you discussed risks that were related to stimulant use or sleep deprivation or cardiovascular strain or psychosis, include that. If you recommended medical evaluation or higher level of care, document that clearly. Good documentation is going to support continuity of care. It supports your professional accountability and a more accurate case understanding. So, in stimulant work, presentations can change quickly. Good notes are going to help preserve the clinical picture and support good decisions over time. And that's especially valuable when cases are high risk or they involve multiple providers. So before moving toward the end of this lesson, I want you to check your understanding of these major concepts. Start by reviewing dopamine and norepinephrine. Can you explain how the stimulants are affecting these neurotransmitters and why that leads to the increase in energy and drive and alertness and reinforcement? That connection is central to understanding why stimulants feel compelling and why the crash feels so severe. Next, I want you to think about sleep deprivation. Why is it such a major issue in stimulant work? Your answer should include not only fatigue, but also the impact on mood and judgment, paranoia, and psychosis risk. Then I want you to consider the signs of stimulant intoxication. Can you identify them clearly and distinguish them from other types of substance presentation? And then finally, think about the red flags. Which signs would make you more concerned about safety or instability or maybe a need for a referral? This knowledge check is about practical recall. In real counseling work, you're going to need to be able to recognize these patterns and respond in the moment. That's why reviewing them actually matters. Now, we can apply this lesson to a real or hypothetical client. So start by identifying the stimulant pattern. Is the client using cocaine or methamphetamine or prescription stimulants? Are they using occasionally, in binges, daily, or unpredictably? And once you identify the pattern, consider the major risks. Is there sleep deprivation present? Is the client crashing hard afterward? Are there signs of paranoia or physical strain or emotional volatility? Then you're going to decide how you're going to respond clinically. What, what would you ask next? What education would be the most relevant? Would you need to assess immediate safety more carefully? Is a referral indicated? See, this exercise is designed to help you take the stimulant pharmacology and move it into the real case thinking. And that's the real purpose of this course. It's not just to help you know about stimulants or opioids or alcohol. It's to help you respond better when somebody's stimulant use is affecting a real person in front of you. The more often that you practice that kind of application, the more naturally it's going to happen in your work. So as I start wrapping up this lesson, the key takeaways should be pretty clear. Stimulants are going to increase activation in both the brain and the body. And that activation may look productive or energizing at first, but then it's going to quickly become dysregulating. Right? The dopamine and the norepinephrine kind of help explain the major effects, including the reinforcement, the drive, the alertness, the anxiety, the agitation, the physical strain. And then the sleep deprivation is one of the most important parts of the stimulant risk. It's not a side issue. It's central. Crashes and withdrawal, they also matter because they're shaping the relapse risk and the motivation and emotional functioning. And we know the client's going to cycle between intense activation and intense depletion, and both phases affect their treatment. And another key point is that stimulant presentation can shift rapidly. The same client may appear highly energized one day and then deeply depressed or exhausted the next. And understanding that variability is going to help you interpret what you're seeing more accurately. And that is one of the most useful clinical lessons in stimulant work. So in the next lesson, we're going to shift into cannabis and hallucinogens. And these substances often come with a different public image than alcohol or opioids or stimulants. And they're probably minimized and misunderstood, or they're wrapped up in cultural myths about safety or spirituality or harmlessness. And that makes the counseling work different, but no less important. Because we're still going to use the same framework that we've been building through this course. We're looking at how the substances are affecting the brain, how that shows up behaviorally, what the major risks are, and how your role fits into assessment, education, and referral. And, the substance changes, but the clinical thinking stays consistent. And that consistency is part of what's making you stronger as a counselor. You're not learning a separate mindset for each drug. You're learning a structured way of understanding substance effects and applying that understanding in practice. So just take a moment to reflect on the stimulant lesson as a whole. What patterns stood out the most to you? Was it the role of sleep deprivation? Is it the intensity of the crash? The risk of paranoia and psychosis? Or the way that stimulants can look functional at first? Identifying what stood out is going to help you recognize where your learning is becoming more concrete. Now, think about your assessment process. What would you ask differently now when you're working with a stimulant client? What would you ask more clearly about binge patterns, or their time awake, or their crash symptoms, or any cardiovascular complaints? Would you look more carefully at paranoia or irritability or impulsive behavior through a pharmacology lens? Also consider what risks you would emphasize more clearly with clients. Reflection is going to help turn information into action, and that's where the real skill building is going to happen. Now you've completed lesson 5, and we have built a strong understanding of stimulant pharmacology from a practical counseling perspective. You've seen how stimulants increase activation, how dopamine and norepinephrine are shaping the effects, and how those brain changes are showing up in mood and sleep and behavior and risk. And we explored how the client stimulant use is going to lead to crashes, how it leads to withdrawal and paranoia and psychosis. It's going to lead to the physical deterioration and the cardiovascular strain. But most importantly, we've connected these concepts to real counseling work. And now you're better equipped to assess stimulant patterns and interpret presentations accurately and respond with a stronger clinical judgment. And this lesson also sets up a useful contrast for the next one. Cannabis and hallucinogens often look very different on the surface, but they're going to require careful understanding and clear assessment. And the same practical framework is going to continue. And that's what makes this course coherent and clinically useful.